Assalamu alaikum wa rahmatullahi wa barakatuh. A very warm welcome to everyone, and thank you for joining us today in the basic dermatology curriculum organized by the Saudi Society of Dermatology and Dermatologic Surgery. This is a 5-week educational course running from November through mid-December. This is a recorded session and will be made publicly available on the Society's official platforms after the course completion. Our first session will be delivered by Dr. Hesham Alshaikh, who is a dermatologist and Mohs micrographic surgeon at King Faisal Specialist Hospital and Research Center. Dr. Sheikh has graduated as the class valedictorian from King Saud University and completed his dermatology residency at the Medical University of South Carolina, where he also served as chief resident, and went on to complete a fellowship in Mohs micrographic surgery and dermatologic oncology at Memorial Sloan Kettering Cancer Center and Weill Cornell. He is also a past recipient of the Presidential Citation Award from the American Academy of Dermatology. Thank you very much, Dr. Hesham, for joining us today. It's an honor to have you with us.
Thank you, Houriah, for this warm introduction and for organizing, and to you and all the organizing committee for putting the structured curriculum, and hopefully everyone find this very helpful. So, without further ado, we'll get started. First of all, I hope everyone had a good weekend, and kudos to you joining in Saturday night for this educational lecture. I'll be starting off the course with a light lecture about dermatology terminology and note writing. Um, and so the things I'll be talking about mainly, we'll first start talking about skin anatomy and then dermatology terminology, and I'll be focusing about three main components: morphology, color, and distribution. Those are the main components. Whenever you look at a skin rash, you'll be able to reach towards your diagnosis, or at least narrow whatever you're thinking about, and narrow it into few possible differentials. And then at the end, I will be talking about note writing. What are the components of outpatient and patient note that are relevant to dermatology? And then few tips and advices about templates and dot phrases that could be helpful depending on whatever electronic medical records that you're using. And so, as we all know, the skin is composed of epidermis, dermis, and subcutaneous fat. This is very important to conceptualize whenever you're looking and evaluating a skin rash. You want to know, is this located in the epidermis, dermoepidermal junction, dermis, or subcutaneous fat? Each pathology located in every layer would look differently in terms of color, where there will be any secondary changes. And if you don't know what you're looking at, you want to do a biopsy, what level of biopsy you should be doing. If you should be doing a shave biopsy or a punch biopsy or an incisional biopsy, it's not always that you have to do a punch biopsy. If you're looking at a pathology located at the epidermal level, let's say a papillosquamous disease or like superficial dermis, a shave biopsy would be sufficient. If you're looking at a pathology at the deep reticular dermis or subcutaneous fat, let's say a dermatofibrosarcoma or dermatofibroma, then probably a deeper punch biopsy would be more diagnostic and relevant, or sometimes even an incisional biopsy would be more helpful. The reason is if you provided a pathologist a sample that is not really relevant, or it's not really encompassing whatever you're looking for, you're going to get inconclusive results. And so that's why it's really important to think about whatever the skin anatomy whenever you're looking at a skin rash. And also think about the structures that are present in each layer. And so we mainly what we have in our skin mostly located in the dermis in terms of blood vessels, nerves, pilosebaceous unit. And this is really important whenever also you're providing treatment. If you're injecting, if you're doing intralesional injection, what are you targeting? Are you targeting hair follicles, eccrine glands? And that also varies depending on what pathology you're actually treating. And so, in terms of dermatology terminology, we'll start off with morphology. And morphology typically is divided into primary and secondary lesions. Um, Primary lesions are really helpful and is seen in most of the dermatological conditions, but not always. Um, and so we'll go over these one by one. So the top left photo is representative of a macule, which is a flat skin lesion that is less than 1 centimeter. The top right photo is a patch, which is a flat lesion that is more than 1 centimeter. Is the 1 centimeter cutoff, is it critical? Honestly, whenever we're looking at a skin rash, we don't have a measuring tape or ruler that we do it every time, but it's a subjective and just a call. So if you call something in between a patch or a macule, no one is going to fault you. Um, but just knowing these is helpful whenever you're communicating with your colleagues or your attending whenever you're describing a skin rash. Papule is a raised skin lesion that is less than 1 centimeter. Plaque is similar, but it's more than 1 centimeter, and this is represented on the second photo on the right side. Nodule is kind of similar to a plaque, but it's not as wide as a plaque. And often, if you feel it, there will be a deeper subcutaneous component or deeper dermal component. Vesicles and pustules, they're fluid-filled lesion. They're small enough, less than 1 centimeter typically. Pustules are they're filled in pus. Sometimes it's infectious, sometimes it's not infectious. It's not always it's infectious. Vesicles will be clear, fluid-filled lesions. Bulla also is a larger, basically vesicle, and it can be translucent or not filled with any pus or blood, or it can be blood filled. And so you can add a descriptive to it and call it hemorrhagic bulla or kind of pustular bulla, and it depends whatever is the content of the bulla. In terms of secondary changes, sometimes you'll find it um, in addition to the primary lesion, or sometimes you're only going to see a secondary changes in the skin. And these are also helpful clues in determining where and what exactly the pathology is. And so, for example, the top left corner is a scale. And so, whenever you're seeing a scale, it's not always the case, but you often think of something pathology within the epidermis, a papulosquamous, or any other pathology that is affecting the epidermis. In this case, it's the photo is representative of psoriasis. And it's not always the case, but oftentimes it's just due to more rapid cell turnover. That's why you're seeing the scale on the top. Crust, which is the second left photo, it's basically a dried fluid when it's exposed to air. So sometimes it can be a serum crust, sometimes it can be um, a infectious crust, like more like what we see in impetigo. Um, and so that depends on the way it looks. If it looks honey colored or gold, that more likely to be infectious. If it just look a faint yellow, then that's more likely to be just a serum crust, and that is related to the fibrin in our serum. It gives you that yellowish color when it's exposed to air. Excoriation, secondary mark, you may only see that in some of the pathologies. Um, and this is often you're going to see it in a linear fashion because that's an external factor, not an internal disease. It's something done from the outside, and so often it will follow more of a linear or a well demarcated kind of pattern. Erosion is often a loss of the epidermis or just the top layer of the skin, and that can be represented in many pathology, neoplastic and non-neoplastic. An ulcer, on the other hand, is a deeper tissue loss. And you'll often find different discoloration because you're getting exposed to the deeper tissue. And so you may find yellowish discoloration on top of the ulcer. And that's again related to the fibrin as part of the serum being exposed to air. Fissure on the top right corner is basically a crack in the skin, and that can be due to extreme xerosis and dryness, or can be due to a primary epidermal or skin barrier dysfunction, like in atopic dermatitis. Atrophy, you would recognize it basically if you feel it, you're going to feel the skin is soft and easy to wrinkle. But also, if you look at it, it will be much shiny and more vascular because it's thin. You're exposing the blood vessels and the papillary dermis. And so it look way different. You'll be able to recognize immediately. Lichenification is basically a thickening of the skin due to chronic ongoing inflammation. And just by looking at some of these rashes like lichenification, atrophy, and fissure, you'll be able to tell that this has been going on for a while. If a patient comes into your clinic and tells you that this has been going on for a week and you see these on the skin, then you know that you're not getting an accurate history. And then the last thing is a scar. A scar, this photo being shown here, representative of hypertrophic scar, but you can see scars in many different shapes and many different variety, atrophic, hypertrophic, keloid, and there are many, many other kind of scars. The other thing that it's important to look for and to think about, what are the colors that you're looking at? Are you seeing a red lesion? Are you seeing a pink, yellowish lesion? If you're seeing yellowish lesion, that's a helpful clue. You may think of, is it a cholesterol deposit? Is it a lipofuscin deposit? Um, if you're seeing a purpura, it's more of hint toward a vascular process. Um, if it's hyperpigmentation, you start thinking, is it a more melanocytic perforation or an inflammation that uh, basically stimulated the melanocytes and you got more melanin pigment in the DG junction, or is it a deeper pigmentation within the dermis? And the deeper you go, the more grayish or bluish discoloration you're going to get from melanin pigment. Similar thing, if you lose a pigment, is it due to melanin loss or melanocyte loss, or what is happening exactly? The other part of morphology is distribution. You should look for if the rash is localized or is it disseminated, if it's unilateral or bilateral, um, and so on. And so you can literally look at a skin lesion and let's say, for example, herpes zoster. It's a unilateral process. So whenever you see it in a linear fascia or dermatomal, you can think of herpes zoster. If you see it a bilateral or more disseminated toward the upper chest, then it kind of a similar morphology, but you start thinking that this can be herpes zoster, although it can happen, but it goes down in the ear differential, and you start thinking about it could be Grover's disease, is it could be Derriere disease, kind of similar location, but just the way it's presented, the distribution can give you helpful clues to eliminate or put some of your differential high up and some of it a little bit lower down. Configuration of the lesion, you can put this as part of distribution or morphology. It's basically how the lesion is looking, basically. So circinate or nemular lesion, when it's a round or coin-shaped lesion, this is often you can see it in nemular dermatitis, archiform lesions that looks like an arc or curved shaped linear lesion. Oftentimes this is exogenous and not a primary, although in some infectious process it can happen, or some genetic disorder can happen in a linear fashion. Serpiginous, this happen in very unique and limited category of diseases, and when you see it's helpful. Annular, when you see a round lesion with a central clearing, like what you see in tinea or subacute cutaneous lupus. Target whenever you have a concentric rings that look like a dartboard. And this is helpful because sometimes you see a rash and you think, is it this EM? Is it drug eruption like TN or SJS? And typically in SJS and TN, you see a typical targeted lesion. Although that's not always the case, but it's a helpful distinguishing factor between EM, for example, and TN. Gyrate erythema or gyrate rash is whenever you see a rash that is whirling in a circle. And zosteriform or dermatomal whenever it's following a dermatomal pattern. So linear can be an outside job, like a trauma or excoriation or an allergic reaction, or it can be sporotrichoid, which is an infectious process. And sporotrichoid is like it's a description that any rash that looks like a spore trick spread, which is a fungal infection. And most of the time, whatever is looking like a sporotrichoid pattern is going to be an infectious process. And dermatomal, again, it can be herpes zoster, or it can be genetic, or genodermatosis kind of pathology. And so, again, when we're looking at a skin rash, start doing that mental exercise. What I'm looking at, what color I'm looking at, and then where's this located? Based on these three things, you'll be able to know the diagnosis immediately, or at least say, is it one or two, or at least know what category of disease you're looking at. Is it inflammatory? Is it neoplastic? Is it drug related? And if it's inflammatory, is it infectious? Is it non-infectious? So it's really helpful method of doing it. And eventually it will be just a pattern recognition, part of your brain and thinking. Um, just looking at it, and you'll be able to tell this is A or this is B with time. Now we'll move on to the second part of the lecture, which is note writing. So in dermatology outpatient notes, there are few components that probably relevant and important to document. And this is also applies to most other subspecialty outpatient notes. You want to know the chief complaint, obviously. In HPI, there are a few points that you want to ask about. You want to know the onset of the rash. Is it on and off? Is it persistent? And then what are the associated symptoms? And more importantly, you want to know if the patient had any prior treatment or prior evaluation. In past medical history, you want to know if the patient is a cancer patient, is a patient autoimmune diseases, has any autoimmune disease, and then what medications they are on. And that is relevant because if you want to prescribe something, you want to make sure that it's not interacting with whatever medication they're taking. And also, um, if you're suspecting a drug-induced rash, then you want to actually do a more detailed drug review. Past surgical, sometimes it can be relevant, sometimes it's not, depending on the chief complaint. And then social, I feel like it's important to know what are the patient hobbies and job. This is, one of the way of um, communicating with patients, and just to remember what patient you're seeing. By looking at the chart, you see whatever their hobbies is, and then you start remembering what patient you're going to see. And obviously, allergies are important to document. And then moving on to the physical exam, general is part of any physical exam. And then moving on to skin, that depends on the patient chief complaint. If a patient coming in with eyelid dermatitis, then obviously that's the main thing that you're going to look for. If the patient has a history of melanoma, then you need to do a full body skin exam. Um, and also can be tailored again to a patient complaint. The patient coming in with an elbow skin rash, and then you think that's psoriasis, then you should actually look for all these psoriasis common areas like knees, lower back, nails, scalp, etc. So that you can do more expanded focus that clinical exam depending on the chief complaint. Lymph nodes, again, depends also on whatever you're looking at. If you're looking at infectious process, lymphoma or skin cancer, then ideally you should check the drink lymph node. Eyes, oral cavity, genitalia, that often depends if you're looking at autoimmune disease or drug eruption, then you should examine those areas. And then lab and imaging, depending on the electronic medical record that you're using, sometimes you can pull the imaging and lab into your note and review it, or sometimes you just have to click on the tab and review it in a separate tab. And then what I would do is document in your note whatever labs and imaging you reviewed, and you just say that you reviewed those imaging or lab, depending on the case. And then in assessment, you'd write your diagnosis or diagnosis list, depending on whatever the patient is coming for. And then I like and plan organize it by problem. And so if the patient having multiple problem, you want to, instead of listing whatever treatment you did for the patient, you organize those treatment depending on the problem. And so for alopecia areata, what you actually did, for atopic dermatitis, what you did. And then be detailed as much as possible. That makes it much, much easier for you whenever you're seeing the patient next time. For inpatient, it can be slightly different. And so you would obviously know and want to know and document what is the admission reason. And oftentimes you get these information from your whoever want the consult. And so if let's say if general surgery is calling you, then you ask them what is the admission reason, why the patient is in a hospital, what is the reason of consult, and then what the duration of hospital stay. Is the patient just got admitted today or yesterday, or has the patient been here for a week or maybe for a month? That makes it a huge difference. And then when did you notice a skin rash? Sometimes they tell you that they just checked on the patient today and they noticed the skin rash, and sometimes they can be more detailed about it. If the patient, if you're suspecting a drug eruption, I would do a detailed drug review. In some hospitals, sometimes there are other services that can help you with that, like allergy immunology. But I feel like doing a detailed drug review and trying to find whatever medication is causing or the culprit medication for the skin rash is part of our job and part of our dermatology job. And if you're not doing that exercise, mental exercise, you're going to lose it over time. And it's often, honestly, it's oftentimes there, and 80% of the time, you know the medication. You ask for a couple lists of medication that are more commonly associated with that certain eruption. Not 80% of the time, it's going to be one of them. In 20% of the cases, it's going to be a little bit more difficult, and you have to dig in and you have to look at the timing to figure out what exactly is the culprit medication. And then templates. Templates are really just a full structured note with predefined sections and areas to fill. It can be a procedure template, it can be a new or follow-up notes, and it may contain smart phrases, smart lists, or smart links that can be included in the template. And we'll talk about these in details. And this is a little bit, it can vary depending on whatever electronic medical record that you're using. Um, but what I will say is templates are really important. And this is and just an investment. Like there's an investment in money, investment in education. There's an investment in electronic medical record in your time. Whenever you're starting your residency or your new job, just sit with the electronic medical record team and just ask about whatever functionality you can do with the EMR just to make your life easier and how to expedite your note writing process. So this is, for example, a procedure template. This is laser procedure. You can name it a KTP laser procedure. And by just clicking on it, the only thing that you have to fill in here is the treatment session and the laser setting that you used. This literally takes less than half a minute of your time, as opposed to writing this every time. Same thing, you can do it for a note. You can um, click, for example, acne follow-up note, and everything is going to be pulled down. The at name at age at, or at six at, those are smart links, meaning those are going to pull whatever the patient name, age, or sex from the electronic record and pull it to your note immediately. And so, for example, if it's me, it will say Hesham Alshaikh is 31-year-old or 32-year-old who's referred for evaluation. And so it just makes it easier into pulling in patient information into the note. And then the acne treatment in between brackets, this is a smart list. So when you click on it, you're going to find a different treatment. So doxycycline, isotretinoin, benzoyl peroxide. And so you just click whatever treatment the patient had tried before, and it would be pulled into the note immediately. And again, those functionality is not available in every electronic medical record, but there might be alternative. And it's really worth sitting with your EMR team to just figure out whatever is available on whatever you can done, whatever you can do. Um, Dot phrases or smart phrases, they're the same thing. Basically, they're a short command that start with a dot that expands into predefined text when written into a note, message, or order. Basically, they're a quick text shortcut and it can be used as part of your note documentation or patient education. And I'll show you how to do it as part of documentation or patient education. Sometimes in some electronic medical record, there is no a dedicated tab for patient education. And so basically, what you can do is have that dot phrase put in your note and then copy and paste into Word document then you can print it to the patient, and then you basically delete whatever dot phrase you used into your note. So to use a dot phrase as part of your note writing, um, let's say you saw a patient with bullous pemphigoid and you want to start him on Cellcept. You discuss risk and benefits of Cellcept, side effects, lab monitoring, etc., etc. I don't want to write all of that. I don't want to spend 3 or 5 minutes writing all of that. So I'm just gonna pre-create this in my EMR. Whenever I want to write .celcept, everything is going to be written. And so you can imagine how much time saving you can do. And you can do this on all the common medications. You can do it on whatever counseling you want to do. And that just saves you a lot of time. And often I will say, it's going to actually take quite some time to do a lot of diseases or a lot of medication. You don't have to do it in one setting. You just do it gradually over time. And by 2 or 3 years, you actually have a good list of shortcuts and templates that you can, for the rest of your career, you can use it and just save your time when documenting. This is, for example, a patient education. So you're seeing a pediatric patient, atopic dermatitis, and you think that they're colonized. You want them to do a bleach bath. Instead of writing all of that, you just write dot bleach, and everything is going to be written. That saves you a lot of time, and also it's just much more efficient way of doing it. And I'm pretty sure, I mean, there might be different ways of doing it, but I'm pretty sure the dot phrase is in a lot of the electronic medical records should be available. And so that's all what I got today. Hopefully that was helpful. And I'm happy to take any questions anyone have. Thank you so much.
يعطيك العافية Dr. Hesham for the wonderful lecture, and thank you so much for your time and for joining us today. So now we will open the floor for a 10-minute Q&A session, and this will not be included in the published recording. So feel free to type in your questions in the Q&A tab.